All right, let's get into it. Today, we're basically tearing up the old rulebook for managing diabetes. The latest clinical standards are out, and believe me, they represent a huge shift in thinking. We're moving away from just chasing a single number on a meter to a much smarter, more complete approach to care. So, what's the big idea? For years, the mission was pretty simple: control blood sugar. That was it. But these new guidelines are making us ask a way bigger question. Beyond just glucose, what's the real goal here? And the answer to that is changing the entire game plan. And that brings us right to the heart of this new playbook. What we're seeing is a fundamental change in strategy. It's about getting away from that rigid, one-size-fits-all model and moving towards something that's way more dynamic, something that actually adapts to each person's unique health situation. Yeah, this new story is all about treating the whole person, not just the condition. It means looking at everything, from heart disease risk to kidney health, and baking things like weight management into the plan right from the very start. It's tailored, it's intelligent, and it's truly holistic. Okay, so let's kick things off with type 1 diabetes. Now, the main goal, managing blood sugar, that hasn't changed. But the tools and the strategies we use to get there, they've gotten way more sophisticated, with a huge new focus on patient safety and, just quality of life. So the foundation for managing type 1 still relies on these core tools. You've got insulin pumps that give a continuous flow, or you have multiple daily shots. But the real game changer here is the specific kind of insulin that's now being pushed to the forefront. And here's why. The guidelines now strongly prefer what are called insulin analogs. The reason is simple, but it's absolutely crucial. It's all about lowering the risk of hypoglycemia, which is when your blood sugar drops dangerously low. This is a massive step for patient safety, helping to ease one of the biggest daily fears for anyone living with type 1. And technology isn't just a cool extra anymore. It's now considered a core part of standard care. We're talking about getting people on continuous glucose monitors, or CGMs, and automated insulin delivery systems as early as possible. These things don't just improve the numbers, they take a huge mental load off the patient every single day. But here's the thing, all the tech in the world is only half the battle. The guidelines make it super clear that patient education is more important than ever. This means really understanding how to adjust insulin for meals, and not just for carbs, but for fats and proteins too. It's about knowing how to handle changes from exercise or being sick. And of course, regular check-ins every 3 to 6 months are vital to make sure the plan is still working. All right, let's switch gears to type 2 diabetes, because this is where the changes are, frankly, revolutionary. The new playbook completely tosses out that old, slow, wait-and-see approach and replaces it with a really proactive, decisive strategy right from day one. This is a huge departure from how things used to be done. Instead of starting one medication, waiting, then maybe adding another one years later, the guidelines now say we should think about using a combination of drugs right from the get-go. The idea is to hit those treatment goals faster and more effectively, which can make a massive difference in the long run. So what's making this new approach possible? It's powered by two key types of medication. First up, we have the GLP-1 receptor agonists. These things are true multitaskers. They don't just help with blood sugar, they also help with weight management, and, this is huge, they provide critical protection for the heart and kidneys. And the second powerhouse group, the SGLT2 inhibitors. Now, like the GLP-1s, they're great for glucose control, but they have this really unique, powerful benefit. They are proven to help prevent heart failure. So for anyone who already has heart or kidney issues, these drugs have become a go-to recommendation. This slide just lays it all out perfectly. You can see how treatment isn't a straight line anymore, it's a decision tree. Look here, if a patient has a high risk for heart problems, the first choice is a GLP-1 RA, that's a receptor agonist, or an SGLT2 inhibitor. If they already have heart failure, you lean towards an SGLT2 inhibitor. If weight management is a big goal, a GLP-1 RA is recommended. And for a specific type of liver condition, there are other great options. This is exactly what personalized medicine looks like in the real world. With so many great options, you gotta know which ones play well together and which ones don't. It's all about smart combinations. For example, pairing insulin with a GLP-1 can give you some amazing added benefits. But on the flip side, the guidelines also warn against combinations that don't add much value, like mixing DPP-4 inhibitors with GLP-1s. It's all about being strategic. Okay, for our last section, let's talk about insulin and type 2 diabetes. For a long time, insulin felt like the end of the road, right? The last resort. Well, that view is completely outdated. Now, it's seen as a powerful tool that can be strategically woven into a treatment plan much, much earlier. You can actually make insulin therapy work even better by combining it. Pairing it with a GLP-1, for example, can lead to better glucose control, help with weight, and even lower the risk of hypoglycemia. And just because you're starting insulin, it doesn't mean you stop everything else. Those other medications can keep working together to give you that full metabolic support. So, when is it time to start insulin? The guidelines give us some really clear signs to watch for. Things like symptoms of high blood sugar, being super thirsty, an A1C level over 10%, or a blood sugar reading of 300 or more. If you see these signs, it's time to seriously consider insulin right away. And this all brings us to what might be the single most important message in this entire new playbook. We can't afford to wait. There's this thing called clinical inertia, which is basically a fancy way of saying not acting fast enough. If a treatment plan isn't working, you have to make adjustments without delay. Procrastination is the enemy of good care, and these guidelines are basically a call to action. So when you step back and look at all of this massive shift towards personalized, proactive treatment, it makes you wonder, right? We've gone from one playbook to maybe a dozen different strategies. But as we learn more about genetics and individual risks, are we heading toward a future where every single person with diabetes gets their own completely unique playbook? That's the really exciting frontier that these new guidelines are pointing us towards.